Let's start with this question. A woman undergoing elective cholecystectomy for symptomatic gallstones. During the surgery, surgeon encounters unclear anatomy due to severe inflammation and callets. So you understand, whenever we are doing a cholecystectomy, what we need to see is the critical view of safety when you are dissecting the Callet's triangle or the hepatocystic triangle. So in that case, if you are having difficulty, what should you do? Should you just keep doing things? Or do you do something which is called as some rescue techniques like a timeout? So what do you do in these? There are some bailout things which you can, so that you can avoid injuring any important structure if the critical view is not ascertained. The first one, proceed with clipping and dividing the structures as visualized. This is an absolutely no. This is the incorrect answer. This is not a bailout procedure. Convert to open, yes. Whenever you have a doubt, one of the ways is do an open cholecystectomy. If you are having too much difficulty, have no shame. You are okay if you avoid the procedure. Remember, patient safety is first. And you can sometimes perform a subtotal cholecystectomy where a little bit of the gallbladder may be left behind if you are not able to attain the critical view. Now let me show you what is given in Bailey. These are the bailout techniques you may have to do if you are facing difficulties in a cholecystectomy. You can abort the procedure, convert to open. These were in the choices. You can perform a subtotal cholecystectomy, but there are some more things you can do. One is you can do a rescue where you put a tube in the gallbladder. That is called a tube cholecystostomy. Like, you know how we do feeding gastrostomy, something similar. You put a tube in the gallbladder, bring it out from the abdomen, later do a cholecystectomy, maybe when the inflammation subsides. And of course, you can do a fundus first approach for cholecystectomy. These are the rescue procedures, bailout procedures you must know for entrances and also if you are going to become a surgeon. This is a very interesting question. It's actually not that difficult. Patient with poorly controlled diabetes presents with a swollen, painful lesion on the posterior aspect of his neck and shoulder. So this is on the back of the neck and shoulder. He's an uncontrolled diabetic. And trust me, in all the exams, they love asking these kind of wound-related questions. The lesion has multiple pustular openings, discharging pus. What is the diagnosis and management? So this is the classical image of a lesion on the back where there are multiple sieve-like openings. This is nothing but a carbuncle. A carbuncle is a staphylococcal infection leading to gangrene of the skin and the subcute. And this kind of a gangrene typically starts giving discharging sinuses, which makes it look like charcoal. That's why the name carbuncle. Carbuncle means charcoal. So it is not a cellulitis. Remember, cellulitis, there will just be some redness. Cellulitis means inflammation of the fat. So it is a carbuncle. Carbuncle is a type of kind of like a wet gangrene. It's an infection. But are you going to do IND under LA? Please don't do IND under local anesthesia. It is gangrene. All this tissue will have to be removed. In IND, you just make a nick and you drain the pus. That's not what you're going to do, and definitely not under LA. You are going to do debridement. Debridement means normally what is done in this condition, you take an incision like this, a cruciate incision, go inside, remove all the debris, and you cut out the skin flaps. Basically, then you will end up leaving a saucerized or a marsupialized ulcer. That is what you will see at the end. So that is going to be the treatment of carbuncle. Excision with a cruciate incision and debridement. And of course, you will give antibiotics because it's an infectious condition. Very interesting concept, something that you must know. And students often ask me a lot about this. Patient with a metastatic breast cancer is started on chemo. That's not what they are asking you. After 2 cycles, there is a 35% reduction in the diameters of the target lesions. So basically, you are giving chemotherapy for LABC, locally advanced breast cancer, to downstage it. So it's not actually metastatic, it should be LABC, and you are trying to downstage it. So when you are going to downstage it, students always ask me that, sir, if you are giving chemotherapy pre-op, how many cycles will you give? And when do you stop? Do you give all in the neoadjuvant setting, or will you give some neoadjuvant, some after the surgery? because it's LAPC. And what is this RECIST criteria? It stands for Response Evaluation Criteria in Solid Tumors. So what is done here? Understand, if I am giving neoadjuvant chemo, normally I give 2 cycles or 2 to 3 cycles. I am telling you what is given in Bailey. I give 2 cycles of chemo and then I assess response. Right? Then I will assess response. Now, what am I seeing? I'm seeing how much the tumor has shrunk. Here, what I'm seeing, 35% of the tumor has shrunk. 65% is still there. If 35% has shrunk, then it cannot be a complete response. Okay, it's not a complete response, but definitely it has shrunk. If it shrinks more than 30%, I call it a partial response. That is the answer to this question. Okay, so answer to this question, more than 30% shrinkage is going to be a partial response. And this is again what is given in Bailey, exactly line by line. So what are the 4 categories when I'm giving neoadjuvant chemo? Normally, after the second cycle, I assess the response. If the full tumor has disappeared, sometimes this happens even with 2 cycles of chemo in breast cancer. Lesion is undetectable, complete response. Anything more than 30% but not complete is going to be partial response. If it's less than 30%, but there is some reduction, it will be called as stable disease. And if it grows, instead of shrinking, it grows, that means it is resistant to the chemotherapy, that will be called progressive. Now, what is the application of this? In the first 2 categories, where there is a good responsiveness, I will give the complete chemotherapy in the neoadjuvant setting. Give the complete chemo in the neoadjuvant setting. Okay, and if it is stable or it is a progressive disease, that means chemo is not working, go for MRM, modified radical mastectomy. Remember, this is for LABCs where I'm giving neoadjuvant, so I will prefer to do MRM. And after MRM, you will give adjuvant chemo, but you will give a different regimen. Okay, so after MRM, you will give a adjuvant chemo, but use something else. If you are giving cyclophosphamide, epirubicin, that you are giving that regimen, CEF, CMF, you change the regimen. Maybe you can now give taxanes. So the regimen will have to be changed, but that will become entirely adjuvant, right? So that is how you are going to use this RECIST criteria to determine the response and also what you should be doing next after you have given a chemotherapy for LABC.